So basically, I'm a hip and knee surgeon, and as an orthopedic surgeon, it is rather daunting to talk in front of very intelligent medics. More than half of this audience is really, medical doctors who we like to call clever doctors, because we don't prescribe many medicines. As orthopedic surgeons, our list of medicines under our book is very, very small. The brain can retain only that much. But having said that, even as a hip and knee surgeon, I think each and every one of us should be aware about certain things related to osteoporosis. So I will run over a few things in the next few minutes. So essentially, osteoporosis is when the bone mass weakens. It is not decreasing the quality of the bone. It is the entire bone mass going down. So if I have to explain that, basically it is not about the bone becoming soft. If somebody has fractures, osteoporosis, because the bone mass is less, will certainly make somebody more prone to fractures. But fractures and bone union, propensity to fractures and the ability of the bone to unite are totally different. So especially for the PGs here, as far as osteoporosis is concerned, yes, fractures are more, but the capacity of the bone to unite with these fractures is still the same. Nothing better to explain osteoporosis than something like this. We talked about famous, Indian TV actresses. So it is the quality remaining the same, only the bone mass going down, or only the actual substance going down. But actually, the material is the same. It is important to know about osteoporosis because it is really, really common. Almost every one of us here, even if we are not doctors, even the non-doctor part of this audience would know somebody in their house having had a fracture, or some auntie or grandmother having a hunched back. Now, the reason this happens is because a lot of fractures, particularly back fractures, are silent. And as time goes by, the height decreases. This is, it affects at least 1 in, like you say, 1 in 3 women around the world. And in India, even though that factor is less than 1 in 3, the important thing about India is that these things happen at a much, much earlier age. So there is the same thing happening, but our bone mass is somehow weaker as compared to the Westerners, which is why this problem is rather relevant to us as much as it is everywhere else. What happens with these things, the main presentation often of osteoporosis is fractures. And the commonest fractures that we see are the back. We just talked about the back getting like this, somebody's height going down. Common fractures are wrist and hip. Now, it could very rarely present as bone pains and things like that, but it is, as you know, most often silent disease. The impact of a fracture happening to somebody who's already in the 7th and 8th decade of their life is huge. And I'm sure you know, for those of you who don't, out of every person who sustains a hip fracture at an age of 65, 70, the data in the world is there. 30% of those people, so if 100 people who you've come across having had a hip fracture, today, 30% of them will be dead in a year's time. So it can be the beginning of the end. The financial impact, of course, is huge because, we have old parents living in homes independently, and suddenly they lose their independence and, everything else that goes with it. Now, it is not something which has to affect an older person. The first common thing to clear here is osteoporosis is talked about as, in somebody which happens only in old people. Now, that picture shows what look like a father and daughter, but there could be factors why osteoporosis can affect somebody in a very, very young age as well. So, somebody who's old can have a very good quality of life, and a young person could be entirely different. So what is it that makes somebody prone to osteoporosis at an early age? It could be endocrine problems, it could be rheumatoid arthritis, it could be many other diseases which they have. It could be, things like medications which they are on. So these are all causes of secondary osteoporosis, which I'm sure the physicians are more clever at detecting. What the rest of my talk, I would say, suppose, talking about the drugs would be more relevant to primary osteoporosis. So primary osteoporosis, when we talk about osteoporosis, we have to quantify it. And the best way to quantify it is by this thing called bone mass. Bone mass, exactly the entire structure of what the bone is made up of. So as when we are born, cartilage gets converted to bone. So bones are soft in the young adults or in the children. As we get older, up to 35, the bone keeps getting stronger and stronger until what we achieve is called the peak bone mass. Now, because of various reasons, if we, like our character is shaped in our childhood, so also, if you don't do the right things for your bones when you're a child, you will not attain that peak bone mass when you're 35, and that could make you prone to osteoporosis much, much earlier. The way to assess osteoporosis in somebody, normally we assess this 60 and above. So what is measured is called the T-score, which is actually your bone mass and how it compares to the average bone mass of a young healthy adult, which is a young healthy adult at age 35, or we are basically comparing our score or the patient's score to the peak bone mass. Now, if you compare it as a T-score or compare everybody's score to a peak bone mass, it would be that a lot of people would look very, very weak, of course. And that is anyway how they are graded. So if you are more than 1 standard deviation below peak bone mass, you are defined as osteopenic or low bone mass, and more than 2.5 standard deviations is actually when you start treating osteoporosis. However, like I said, everybody, when they're going to get old, so I have a lower bone mass than I did 10 years ago at 35. So, am I osteoporotic? If I am an average bone mass as somebody at my age would be, then I probably should be all right. That is the concept when we talk about the Z score. So basically you're comparing your bone mass to somebody who should have an average bone mass at your age. And that is probably what is more relevant in deciding how strongly to treat that patient. Talking about causes, and why people attain low bone mass. This is probably, I don't need to, emphasize more on what probably could accelerate osteoporosis in the, people like me, middle-aged and whatever, as compared to the younger people. But the younger generation certainly is achieving a lower peak bone mass than we did. And you ask any of our youngsters to come home and eat chapatis, they don't want to. This is what they want to eat. This is where they want to have their birthday parties. Forget about the young children. When it comes to exercise, we all like to do exercise and we talk as if we are doing exercise, but, do we really do the right exercise? I come from Goa. This is how Goans do exercise. I don't know how different it is in Vizag. He's sweating as well, you see. Anyway, so it is the right techniques, the right sort of food and all that, which, goes without saying. When we measure bone mass density, it is measured by a machine called as a DEXA scanner, which is essentially X-ray. And the reason we measure specific areas is because these are the ones which are most prone to osteoporosis, specifically the back and the hip. And that is where you can measure and standardize for the population. Bone mass density is available in a few places and that can be a bit expensive. But we'll talk about later whether it is really required in everybody. This is the age of documentation. So everybody, if you want to document osteoporosis, yes, the bone mass is there. There are various other measurements, and all of us have known that CAMs are conducted to screen osteoporosis. Essentially, this is not X-ray, it is just ultrasound passing through somebody's heel. So it is an okay measure, but that can give you a lot of false negatives. So if somebody is detected to be osteoporosis at an age of 40, 45, you know, we have a lot of pharma companies. I'm not saying anything about Cadilla, this is a different issue, but generally we have a lot of sponsored events where people will come and in our OPDs and do this bone mass density measurement. And you have the average 30, 40-year-old going and putting their heels into that hole over there. So it may not really mean anything if somebody is not walking a lot, particularly an executive. His heel bone mass is bound to be less, and that might come across as osteoporotic. But that doesn't mean that person requires treatment. Now, there are specific reasons when we would actually indicate a bone mass assessment, not for everybody who's osteoporotic, but when those reasons are particularly when somebody is not responding to treatment, or for somebody who has other reasons for osteoporosis that you need to get a quantified measurement. Not every measure is worthwhile. Of course, if you have to measure, there are a lot of markers and fancy things available, which I would say are, beyond the clinical spectrum. I would leave it to cases which are more resistant to treatment and secondary osteoporosis. There are a few practical tools out there, and this is a very good tool which is available to everybody, free and online. It is just a questionnaire which is very well given and propagated by the WHO. It assesses your risk to fractures depending on history and clinical examination, and gives a very good indication as to whom you need to treat. So, like I said before, very, very important basic things about diet and exercise. Very, very important. So, back to basics, back to nature. Talking about calcium and vitamin D, Dr. Snehal has mentioned very well already. Calcium and vitamin D should be a part of our diet, and if our diet for whatever reason does not have enough calcium and vitamin D, that is where replacement becomes essential. It is probably more of a requirement in ladies post menopause, vitamin D and calcium. Vitamin D for a lot of us who, even though we live in a sunny country, don't really want to go out, are sitting in AC cabins throughout the day. So that can be one of the things. Particularly for the older person, more important than just replacing with calcium and vitamin D, you can't just pour calcium and vitamin D into their diet. They'll have side effects. There is, of course, you can't give too much of it, but it is important to, instill in them a basic, you can say, education about how to prevent falls. Because despite giving people treatment, if they fall badly, if things at home are not made safe, they can have various problems. Coming to treatment, when would you start treating somebody with or for osteoporosis? So, if somebody's had a vertebral fracture, if you have clearly documented, but in how many patients are you going to do a bone mass density assessment? No. Most of these patients will present to you with fractures, and maybe some of them will say generalized bony pains. You do get a fair bit of an idea looking at their hip x-rays and back x-rays, and with that age, on a general risk, you can start treating. The best, of course, if you want to do it objectively, just do a Frax tool assessment. Coming to pharmacological therapy, there is a lot of drugs over there, but it is best to remember it under two categories. So, if you have to consider the bone as a vessel full of water, it is one way you can fill the vessel with water, or you can prevent, it is a leaking vessel essentially. So, the vessel, imagine it's a vessel or a tank full of water, and the tank has holes at the bottom. As the person gets older, the water quantity in that tank is going to get less and less over time. And this is what is happening with biology. So, with drugs, what you can do is stop the leakage from the bottom, or you can add more from the top. Now, there is only one drug which we have been which has enabled us to add more from the top. But that is not the thing which you start giving everyone right away, because it has other problems. The common things to do are to stop the leakage from the bottom. Calcium and vitamin D, of course, are just dietary supplements, but all the other drugs over there, starting from bisphosphonates, you can have calcitonin, and there's no point going into the details of everyone, because everybody knows that here better than me. You have hormonal supplements, and of course you can have some tissue-specific complexes which become expensive and not very practical. But there's a range of things you can select. But all these things do is stop the remodeling or stop the reabsorption of bone. To add bone, you can only give a parathyroid hormone. None of these drugs are going to act quickly. So, as the diagnosis is slow and uncertain, so also is the treatment going to be very, very slow in order to have effect. You can have quick effects only in something like that, not in osteoporosis. Now, Cadila hasn't come out with an innovation to do that as yet. That's a Japanese medicine, I suppose. It's not going to work on her. It doesn't work on everybody. So you want something which actually works on everybody reliably, and you want to have assessed it properly and give the right thing for the right person. So that is why we have guidelines. You just don't want to give any drug and bombard the patient with drugs there. So we have guidelines as from the American Endocrinologists Association as to what to give as first line, second line, and so on. The first line drug has to be bisphosphonates. Now everybody knows about bisphosphonates, and certain bisphosphonates have been put as first line, certain have been put as second line. Bisphosphonates essentially will help the osteoclasts stop their activity. So the leakage from the bottom is going to be stopped. So there is weekly bisphosphonate, which is alendronate, or there is a yearly one, which is zoledronic acid. Zoledronic acid is very easily available in India now, but the only reason I suppose we would give that to our patients now is if we are worried about their compliance. Talking about a weekly one, it is very easy to administer, but it is whether the patient is going to reliably take it every week and take it according to the specifications. There are of course other drugs which can be given monthly, but that is put down by the association as a second line drug, that is ibandronate. Of course, if patients have other problems like hormonal problems and things like with relation, if they are on hormone replacement therapy or something like that, then you have hormone modifications. Raloxifene acts very well there. It is an estrogen agonist, particularly for patients with pain in their back after fractures. Calcitonin works. So calcitonin is given as a nasal spray, and of course, for patients with high risk or patients with secondary osteoporosis, the drug there, teriparatide, the hormone, is very good and can be given. When it comes to teriparatide, we know it is the only drug out there which can be given to increase the quantity of bone. The best thing about teriparatide is that it is amazingly safe. There is no doubt about that. When teriparatide came in a few years ago, it was at least 5 times the cost that it is now. The downside today for a country like India is that still for the majority of our patients, this would be a high cost. And the cost about, different preparations are there, but the cost is about maybe at least something like 4,000 to 5,000 a month. Now, they have to be administered as injections, exactly how insulin is given, but people will come and teach the patient how to do it at home, and it's not that difficult. It is an entire month's pack comes as a single pre-filled syringe, which is used over a month, and the thing is, it requires a refrigerator at home, it requires that much money, and more importantly, for teriparatide to have an effect, you can't just try it for 1 or 2 months. Minimum, it has to be given for 6 months and above. If the patient is going to take it for less than 6, might as well not give it. The other thing, it is what you need to know about teriparatide is if you have used, for whatever reason, bisphosphonate. We are seeing now in the Western world a lot of problems related to bisphosphonate. Now, bisphosphonate, even though they are the first line treatment, what they do over the longer term is they will make the bone more and more brittle, because it stops the bone resorbing capacity, that is, it stops the bone remodeling. The bone is rendered rather brittle and hard and loses its normal biologic recycling activity, which it becomes more like dead bone. So that bone needs to be given some time for the normal biology to take over before you just start giving teriparatide. So mind you, if any of your patients is on bisphosphonate, the better thing now is to give them maybe for about a year and a half, then give them a break for 6 months to a year, and then start it again. If somebody is on bisphosphonate, don't start on teriparatide. You definitely can't give them in combination. If they are on bisphosphonate for some time, stop the bisphosphonate for 3 to 6 months, then you can start the teriparatide. What we have started seeing also in the Western world is, I must remember to say here, is we saw a lot of patients with fractures. Those who are on bisphosphonate therapy having fractures, those fractures are extremely difficult to treat, extremely difficult to heal, because they are bones which are not having remodeling. Just a few words about newer agents. We don't really have them very commonly available, but you have analogs, antibodies against osteoclasts again, this funny agent which I can't even pronounce actually. Anyway, there is strontium was given in earlier years but has gone out of vogue now. Strontium was shown, it had shown that the bone becomes white, that is on serial x-rays. It looks like it is gaining density very fast, but again, the quality of bone that you get with strontium is not all that good, and we are worried about toxicity associated with strontium. Of course, there are a lot of new drugs on the horizon, but with what we have today, I think these are still going to be far-fetched beyond the reach of our economics. In that sense, just to add to the list, there is antibodies, there is things like, again, similar analogs like teriparatide, and there are inhibitors of things which break down collagen, which might in the long run have promise. Now, when you want to start something new, it is important that assess safety first. We've got something new on the block, we've got teriparatide, we've got a few drugs, we've got to know how to use them. Unless we know, we shouldn't be too excited about new things. The good thing is that, okay, I'll summarize that later, but see what happens when somebody starts something new and, without some good research. So this guy just wanted to get the excitement out of starting something, and he comes back with a rather dreaded side effect. We don't want that. So we are lucky we have companies like Cadila, who probably could invest in some good phase 3, phase 4 trials when these things are introduced. When something new comes, we need to have good assessment of effects, side effects, apart from thinking about the economics, and treat our patients in the best way possible. Thank you.
Yes, the house is open for questions.
Any drug-free natural remedies for this osteoporosis?
Of course, the cabbage. No. I meant basic things, of course. Healthy lifestyle, diet, exercise, a good complete diet should actually, prevention is better than actually curing it. So you can't prevent it entirely, but I mean, just the story of my own family. I don't want to exaggerate too much, but my grandfather walked, at least 10 kilometers every day. He used to cycle till he was 80. My father used to walk 5 kilometers one way to school. For me, even to walk half a kilometer, I had a bus dropping me. My child does not even walk, 100 meters to school. So it is just our generation, what we are eating. So what we can't modify where we live, but certainly we can maybe introduce some better healthy diet, some regular exercise, which will help us go a long way. Absolutely, absolutely. I think that is where we are failing. Right from that is why I stressed on building up your peak bone mass. What we are not doing is in our teens and early 20s, we are not doing the adequate amount of activity and having the right diet to build up the peak bone mass. If we do that and maintain a decent level of activity, I think we should be better. But it's much more easier said than done. There is a lot of debate on whether vitamin K is an essential component to bone metabolism along with vitamin D. So there is some evidence for and against it. Things are not entirely clear, but we still have a lot of preparations out there which have calcium, vitamin D and vitamin A we don't know because there's evidence for and against. But at the same time, what I tend to do if I'm giving somebody calcium for a long time is I tend to change the preparation once in a while. I don't want to give them what you can have with particularly vitamins A, D, E and K. So K is you can have an overdose, and that's what we don't want. So you don't want to give somebody vitamin K all along. Like, there's a lot of analogs on the market with calcium and calcitriol. You don't want to give calcitriol is good in the first 1 or 2 months of your calcium therapy, not after that. So similarly, vitamin K might be good for some time. You don't want to continue it all the time. Because people, especially when you're giving these medications, again, remember, people might be, we have the average 70, 80-year-old parent couple living alone with sons in the US who keep sending tons and loads of multivitamin combinations, and they might be taking all sorts of multivitamins on earth. And on top of that, you add this, you can get toxicosis. Renal disease is the one I can think of. They say not anything specific otherwise. I mean, what is happening now is with this, I mean, I'm an orthopedic surgeon, so I know little on this, I would say in front of a medic, but still, there is, we don't, of course, need to test vitamin D levels for anybody we are giving vitamin D. What we do when we replace vitamin D is we give 60,000 units of vitamin D once a week for 8 weeks. Now, if somebody comes symptomatic with bone and muscular pain, this is what is generally my first line of treatment. But if they haven't responded, at that stage, I might do a vitamin D level. There's no point doing a vitamin D level first because you make the patient spend something like 2,000 rupees for a vitamin D level, whereas your treatment costs you 300 rupees, 8 doses of vitamin D. Having said that, we don't want to just give patients vitamin D because then they can get toxicosis. We don't know what levels would cause toxicosis. We don't know what level of calcium would be high dosage, but generally they say don't take more than 500 milligrams of elemental calcium a day. So, there are tablets which give you 1000 milligrams, but what is eventually available. So, one a day is more than sufficient.
Do you think that stone disease of the kidneys is a contraindication?
No, not with 500,000. No, that has been proved.
And
definitely.
Calcium in the coronary arteries. Do you
no,
think that...
that has not been proved either, as far as I know.
No, any care to be taken?
Don't take an overdose, that's all. If your diet, if you're taking it as a supplement in the diet, don't...
So can we blindly give calcium and vitamin D everyone above a certain age?
In my opinion, if they don't have renal disease and if they are not taking too much else, I think it cannot produce too much of side effects, as far as I know. Of course, if they have other things going on, I would consult a physician. Is a safe answer.
Any more questions?
What is the treatment for renal osteodystrophy?
I would pass it on to a real clever doctor. No, not in my book of. Sorry.
Renal failure, as far as we know, is only a D3 form is there.
Yes, absolutely. Absolutely. It is nothing to do with.
Hypocalcemia is also very common in chronic renal failure
Yeah.
patients. So it is not that danger as you suggest, I think.
I would agree. Yeah.
Except
So-
anyway, we will be monitoring the calcium,
You're monitoring it there.
phosphorus and uric acid, everything we will be monitoring.
Precisely.
So depending on the situation, as the situation warrants, we will.
Precisely. I mean, these are situations where we are monitoring patients. What I was talking about was about the 80 to 90% of practice where we just kind of prescribe, where patients may not even come with a blood report, just want to take from you. Next month, they will go to somebody else, take something else from him and end up taking both at times. So that is what we got to be careful about. If you're monitoring, that's totally a different cup of tea.
Thank you.
Thank you. Thank you very much.
Thank you very much, sir. Thank you. It was really good, knowledgeable, and the fun-filled elements, I think, was more good. Thank you. Yes, I just invite Jayesh Chaudhary, who's the marketing head with Cadila Pharmaceuticals, to give the vote of thanks, and after that, the house will be open for cocktail and dinner.
Oh, well, thank you, ladies and gentlemen. What a wonderful audience we have today. On behalf of Cadila Pharmaceuticals, I thank you all for taking out your time and being a part of iamicon 2016 at Visakhapatnam city today. I thank our chief guest and our guest of honor, Dr. G.V. Reddy and Dr. Dharmarao, for taking out time and sharing insights with the audience today. And our special thanks to our speakers, cardiologist Dr. Damodar Rao and Dr. Yogeesh Kamat, especially taking out time all the way from his schedule and joining us here at Visakhapatnam. I also take the opportunity to thank the event management team, the hotel team, and more importantly, the pharma cadilians at Vizag for making this event a grand success that it is today. And as the event comes close to an end, we remember the words of Shri I.A. Modi, who said that this true celebration of research lies as much in inventions as making medicine affordable to the last man in the society. We at Cadila Pharmaceuticals would like to take this journey forward and delight you yet again with another edition of iamicon going forward. On that note, I convey my sincere thanks to all of you and a lovely audience today, and may I request you to join us for cocktail and dinners. Thank you.